So this is week 5 already. Very, very incredible we're here already. I'm like, okay, week 5. Probably my favorite of all lectures, probably the most difficult for students. So if you don't understand what I'm talking about, please listen to the lecture again or say, hey, Professor Bogart, can we meet for a little bit? I'm not getting this about respiratory, this about cardiac, and I'll try to help it, with you. Try to make it more understandable. Remember, there is a discussion question again and another CJ Sims. You guys have been pretty good with them. Again, if you ever see a 0, go back and look. Remember, you still have a week for last week's Sims if you didn't turn it in, and they are worth 1% of your grade. And it can make a difference if you're that borderline student, okay? So make sure that you do what you can do to get them. So let's go ahead. Let's start with a PowerPoint. You all received it. You also received a matching um, paper. And I hope that you have turned it, either saved it, printed it, whatever you want to do with it. That literally goes through the chapters of all the key concepts that you might see, quizzes, exams, or essay. So very, very important. I made it many years ago when I was doing on ground, and actually that was a quiz I gave to my students to try to figure out 20 different questions. So I've just made it into a handout for you all. So, okay, respiratory. Well, respiratory can either be upper, and kids are full of mucus, right? Full of snot. They don't blow their nose. So where does that mucus go? Up into the into the ears, eustachian tubes. They have ear infections, they have upper respiratory, sinus. That's part of that. And then of course we have the lower, which is more of pneumonia and actually asthma. Now, most of the time, it's a virus. And one of the things that we talk about, especially in the younger children, and I'll mention it more in a little bit, is the respiratory syncytial virus. Now, the respiratory syncytial virus for you or me is a common cold. You don't feel well, you have a cough, runny nose, and you have a headache, and you just feel, ugh, and you take some little Tylenol or some Motrin because you have a low-grade fever. Now, in infants, all that extra mucus in their nose, they can't blow it out. So they're obligatory nose breathers. So clog up the nose and try to breathe to be able to suck a bottle becomes a hassle. That's where the big difference is between the infant, children, and even the adults. Okay. So that's respiratory syncytial virus. It's like, oh my God, my kid had RSV. Well, if you can suction the nose out, they can breathe. Other stuff can happen, other bacteria, but mostly viruses. Now, one of the things that I want you to remember babies are born, they have mom's immune system, but they really don't have their own yet, okay? And mom stuff just goes away. So for the first 3 months, hopefully the baby's protected. And we know that they're given how many immunizations? 2 months, 4 months, 6 months, like a lot, right? Why? Because there's no defense against it and there's no reserve. So they can't, win if they're already behind. Now, at 3 to 6 months, moms go away. Now they start building their own immunities. They start getting all the, viruses, etc., build up the immunities. Now, hopefully we protect them during that time. Then they get to toddlers and we send them to daycare. And what do children do at daycare? They play with toys. And what do they do with the toys? They put them in their mouths. And what do? They share. They swap spit all day long, swap germs. It's not a bad thing because they're old enough now and they can tolerate it. And now they're building up immunities. So by the time they get to school age, the only things that bother them are the infections with bacteria, like mycoplasma pneumonia or strep infections. So increase immunity with age? Absolutely, because you're getting these diseases. Now, otitis media, one of the biggest common things with children, right? Why? Mucus goes to the area of least resistance. Where does it go? Up those big, wide open, short eustachian tubes, up into the middle ear, and now it hurts. And what's in your mouth normally? You have staph. Everybody does. Some have MRSA, some have staph. And where does it go? In the ear. And now you have this infection and this pain. So it's because it's smaller, shorter, and it goes right up there, right? Now, what does a kid look like when they have an ear infection? Well, some of them will hold their ear and they'll hurt, right? But most of the time, what first happens is they stop eating, they stop playing, they just don't look good, right? And when you see a kid not eating, not playing, something's going on. And that's when you look and they have a little fever and they might vomit, their tummy might hurt, etc. You might hear all the upper airway mucus, but this is all part of the ear infection. One of the biggest things is the pain. Now, children coming into urgent care, ER, ear infections. Yes, we're going to give antibiotics. Yes, that is the treatment. But what's our priority to give that child? Something for pain. Because an antibiotic's not going to work instantly, right? Take care of that pain, make them feel better. Why? Well, when a child doesn't have a fever, they're not in pain, they are going to drink and eat and play. And that's what we want. They have a fever. We need extra fluids. No fever, they'll drink that extra fluids. So it's actually why we give that acetaminophen, that ibuprofen for the pain, but it solves many other stuff. So our goal with anything respiratory is to ease their effort, like make them breathe easier, let them be able to sleep, and we don't want other people to get it. So prevent the spread of infection, keep that fever down because they'll drink, they'll eat, and they'll be good. And of course, they always need their hugs when they don't feel good. Now, infectious mononucleosis, this is the kissing disease, right? We think about teenagers, kissing disease, mono, right? It is a virus. It's a herpes like Epstein-Barr virus. Well, Epstein-Barr is noted to be fatigue syndrome type virus, okay? So you're tired, you don't want to move, you're extreme fatigue, but it's the sore throat that first starts the whole going to the doctor. And you might, the aches and the pains, and you might have swollen lymph nodes. You also might have a swollen liver and spleen. This is part of mononucleosis. All of those lymph nodes, which is spleen and liver too, get swollen. Now, what happens with infectious mono? The child goes to the doctor, sore throat. They do a culture and they don't feel good. Fever, general body aches. They do an influenza test. They do a strep test. They do an RSV test. They do a culture. Everything's negative, negative, negative. You're sent home. It's going to be a virus. Treat it with fluids, rest, ibuprofen, acetaminophen. Well, 3, 4 days later, they still don't feel well. They go back, and the doctor says, well, I don't know why. Everything's negative. Let's put you on antibiotics. Well, another 3 days go by, and they come to the ER where I worked. And they complain of sore throat, feeling fatigued, swollen, whatever, whatever. And we go, okay, so we're going to do what? Well, let's rule out viral versus bacteria. Do a CBC, right? WBCs are normal, or it's a virus. We're also going to do a monospot test. And that monospot test is telling you that they have mono. Well, if they have all those symptoms, gone through all of that, it's going to be a positive monospot test. So they're sent home. They have a virus. Remember, it's Epstein-Barr virus. We send them home, acetaminophen, ibuprofen, rest. But remember that swollen liver, swollen spleen? I mean, that spleen can get to the point of a big balloon, ready when you touch it can pop. So no contact sports, no roughhousing, protect that abdomen, right? Well, let me tell you a story which emphasizes the point of no roughhousing, no contact sports. I had a 9-year-old boy come into my ER one Saturday morning while I was working, went through all of that, went to the doctor, got antibiotics 3 days later, came to me. We did the exam, we did the blood tests. CBC was normal. It's a virus, monospot positive. The father had brought him. We told the father, we told the son, protecting the abdomen because, it is swollen and it can burst if it has too undue pressure or hit too hard. Well, 1 week later, following Saturday, because I worked every weekend going to school for my PhD. I worked that next Saturday. I was the trauma primary nurse, which means anything that came in on a helicopter, I went and brought it down to the ER. I'm in charge, making sure that child got all the care that it needed. Well, it was a call from the Everglades. Child fell off an ATV. It was the child with mono. Fell on his abdomen, burst his spleen. He arrived DOA. Okay? That's how serious it is to teach these children and parents to protect the abdomen. And I tell you that story so that maybe one of you will prevent another child for doing that. Okay? Now, bronchitis. It is a dry, hacking cough, non-productive, and it's terrible at night. This is the one that you're trying to sleep and you're coughing, 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 coughing. It's a tracheobronchitis, trachea bronchitis, inflamed, cough, cough, cough. So how do we treat it? Well, we can give, it's usually no fever either. It's just annoying. You can't sleep. The biggest thing is a cough suppressant of some sort if you can get one that works for you today, because they've taken many off, believe it or not, out of the pharmacies. Humidity, like a vaporizer, also can help. This is the one that you put them in a bathroom, close the door, put the shower on hot, let the steam go. Sometimes that helps. Sometimes bringing them from the indoors to outdoors actually helps too. But bronchitis usually is a virus. Again, just treat it, the cough, make sure that they can rest. Now, croup. This is something that affects the larynx, the trachea, and the bronchi. And what happens is everything swells. So your upper airway, the air trying to get in, it swells. So it's hard to get air in. So there's inspiratory stridor, okay? Because everything up here in the oropharynx is all swollen. It is usually a virus that occurs it, usually less than 5. And because you can't get air in, you're going to see respiratory distress, substernal retractions, and then you're going to hear them like coughing. It sounds like a seal. I mean, it is so, when you hear it, you're like, oh, that kid is croup. There's no other choice. That's what it is. Now, it is not, it's a virus, so it's no big deal, but that swelling can go into epiglottitis, so it needs treatment. And because it can go into respiratory acidosis, failure, epiglottitis, and you're not breathing. And the treatment is just steroids. Steroids could be a shot, could be a pill, could be a dose once, twice a day, couple of days, but it's just steroids. Now, epiglottitis. Now, what's an epiglottis? Do you remember that from your anatomy? That's that leaf-like structure that covers the trachea when you swallow food or liquid, so that the food goes down your esophagus, not into your lungs, okay? Well, epiglottitis is an inflammation of that epiglottis. It swells up and you can't get air in, or hardly any air. It's usually those children are in that tripod position, just like COPD adult patients, leaning over, trying to find that little angle that lets the air get in to their lungs. They're drooling, they can't swallow, their voice is because they can't even talk. And if you let it go on, it's going to progress to respiratory failure. So, ever have a child admitted, urgent care, doctor's office, doesn't matter, and you seeing this stuff going on, be prepared to intubate that child or place a tracheostomy, because that epiglottis is covering the airway and they cannot breathe. True medical emergency. So, got to keep that airway open. You still, as it's going on, have to maintain the hydration. When you first get these children, they're going to be given what we call epinephrine, but it's in the aerosol called racemic epi. And the epinephrine goes right directly on the epiglottis. It helps decreases inflammation. We're going to get an IV in. Keep that kid calm. Sitting in mom's lap, they're happy. Oh, please let them sit in mom's lap. I don't care if it's in a chair, on a couch, on a bed, it doesn't matter as long as they're as comfortable as they can be. And then we're going to give them some IV steroids. And then to follow that up with that swelling decrease, we're going to give nebulized mist oxygen, just to make breathing a little bit easier. Now, RSV is also called bronchiolitis. So the bronchus are inflamed. It is a common acute viral infection again. And we don't, most normal, healthy newborns, we don't do anything to prevent them from getting it. They can tolerate it. But what if you had a congenital heart defect? What if you had cystic fibrosis or another immunosuppressive disease? There's nothing. So we want to prevent it. And there is a monthly vaccination, immunization that we give from about winter to early spring, about 6 to 8 months. Down in Florida, it's a little bit different. So 6 to 8 months we give it, only the first year. And we give it, it's called Synagis or Pavizumab, and it's a biologic. And what it does, it helps prevent that infant from getting this disease, this viral infection, this RSV, because they breathe out of their nose. It's full of mucus. They're trying to suck and swallow and feed, and they can't. And then, of course, you're going to see that retractions and just really difficulty breathing. So we want to prevent that in those children that can't tolerate it. Now, one of the most common things that we do for children is tonsils, adenoidectomies, and ear tubes, right? Those are the big three. So, what do we need to know about tonsillectomies? Well, let me just describe what they do with tonsillectomies. They go into the back of the throat and the adenoids, and they take a scalpel and they cut out tonsils, adenoids, and they cauterize and make big scabs in the back of the throat. So, that surgery, post-operatively, what are you going to do to prevent those scabs from leaking and bleeding? Well, no irritating, highly seasoned foods. You're not going to gargle. You're not going to stick anything in that throat at all. Even toothbrushing, maybe just a little bit of the front, a little bit. They want to make their mouth fresh. No coughing, clearing their throats, no straws. Make sure that they get their pain medicine. And in children, just acetaminophen or ibuprofen works. And children that will tolerate it. Now, toddlers won't, but maybe at preschooler, an ice collar will make them feel better. At school age, absolutely. And then older kids, because the ears get like pressure, it's almost like going up in a plane and your ears hurt. Well, that sort of feels like a tonsillectomy in older children. So chewing gum, like you would go up in a plane with, chewing it helps clear the ears and prevents that ear pain. Now, if there is something going on 5 to 10 days, odor, pain, that's not normal. That needs to be reported. Or if it's that, the ear pain, fever, cough continues, again, that needs to be treated and go back to the physician to be checked on. But usually within 1 to 2 weeks, kids can go back to normal activities. But remember, it's those scabs can come off. Now, you want a story? I had a 6 or 7 year old child. It was a little girl, just seen by ENT, cleared, tonsils adenoidectomy. She had vomited once in the car and it was blood, so they brought her right to the ER. And of course, she came right back into the triage, which I'm there. In fact, that's where I worked most of the time. And she vomited clots, like a big clots of stuff for me. And you could see her getting weak and pale. I picked her up, brought her in the trauma room, got the doctor, got someone to help, got an IV in her, and I gave her a liter, 1,000 mLs of normal saline. She was going into hypovolemic shock. Heart rate was 160, blood pressure was 60/40, and we got it back, sent her to the OR, got it recauterized, and she was fine. So tonsillectomies, as easy as they are, again, can turn into something, can't they? Now, pneumonia. Well, we think of pneumonia about the consolidation, right? But what can cause it? Bacteria, viral, mycoplasma. Pneumococcal, yes, we have vaccines. Now, what are ways kids can get aspiration pneumonia? Well, years ago, I used to use Johnson & Johnson baby powder. Oh my God, I love the smell of it. But the powder in the air can go in their lungs and cause that. Another thing is just that kid with reflux that they're vomiting that could go back into their lungs. So again, that's a lot of nurse teaching on how to burp the child, sitting them up after feeds, right? Not overfeeding the children. Those are things that we'll need to teach our parents. Now, foreign bodies. I can't tell you how many things I've seen go down into the mouth. The biggest thing of all, believe it or not, is not the dime, it's the penny, it's not a nickel, it's always a quarter. Kids love quarters. In fact, last year, my grandson, who's 9, had a quarter in the mouth and inhaled it. And I'm like, you know, he went to kiss his mom, and there the quarter went down. And of course, it ended up with something different for him. He ended up in the OR. But usually, you get a kid that the X-ray picture looks just like that. We call the surgeon down, and you know how they get that quarter out? They take a Foley catheter, put it down the mouth, below the quarter, blow up the balloon. This child's sitting on the surgeon's lap. They lean him forward and they pull out that Foley and they vomit and the quarter comes up. And you know how I keep that kid calm? I said, you know something? When he pulls that out, whoever gets the quarter first can keep it. So he's not thinking about this coming out. He's thinking about the quarter on the floor, and he goes right to the floor and grabs the quarter, and it's no big deal for him. So again, I made play out of a big situation. What do we do after? Oh, we watch him for an hour or two, make sure his airway's okay. And we tell him, please don't swallow any more quarters. And of course, I give him the quarter. It's not a big deal. I don't want the quarter. I just did that to tease him. Now, pertussis, we do give vaccinations for that, right? But there are children that don't get vaccinated. So what do we do with those children? Whenever you get a child in that has upper respiratory, our number one question is, are you up to date with vaccinations? That will say, okay, I don't have to be as concerned about protecting me or the other immunosuppressed children with a child with pertussis. I've seen cases of pertussis where there was like 5 in the 2 counties where I live, and it is extremely highly contagious. These children go into reverse airflow rooms and they're admitted, they're sick, and they're placed on azithromycin. That's actually the treatment for it. And actually, they will recoup from it, but they are sick with it. Smoke inhalation. Remember the big thing? They're in a house, something happens, there's inhaled smoke. What are we going to do? Make sure you look at the mouth. Is it singed? Is it the airway? Is it the nose? We can determine those things. Also, it's humidified oxygen, 100%. And that helps with them to breathe. Remember, tobacco smoke is not a good thing. Actually, tobacco smoke causes more ear infections and SIDS deaths in infants. Remember, SIDS is from ages 0 to 1 year old, and being around smoke, that secondhand smoke can cause problems. And of course, when mom's pregnant, we always know that one, but that's how it affects children. Now, cystic fibrosis. There are a couple diseases that we'll see that if a parent wasn't tested before delivery for cystic fibrosis, which they're doing today, but if they don't, if you have a child who doesn't move their bowels in a day or a day and a half after delivery, you're going to be testing them for cystic fibrosis. It's one of the signs and symptoms: constipation, no bowel movement right after delivery. Now, another way we could tell is if the mother licked that skin of that infant, it would taste extremely salty. They lose salt like crazy. Like, don't ever hold a salt shaker on a cystic fibrosis child. They're losing it. I don't care. Give them a salt shaker. They can have it. Now, what is cystic fibrosis? There's two organs affected, multi-organ. It's the lungs and the small intestines. What happens is the lungs hold the mucus. And this mucus is like petri dishes waiting for bacteria to grow. So it's going to be constant, 3, 4 times a day aerosols, CPT, chest physiotherapy. We're going to be working those lungs like crazy, or they are going to get full of a bacteria infection, fill up with mucus, and they're not going to be able to breathe. The other thing it affects is the small intestines, and specifically the pancreas. And what happens is they're unable to absorb fat. So they eat fat, right? It's part of formula, it's part of breast milk. So where does the fat go? Well, when it goes down, it creates gas, so a lot of flatus, and it's going to be coming out in the stool. And it's the foulest smelling, greasy, it's full of fat stools that you'll ever see. So lungs, small intestines, it's the pancreas, and they're not absorbing fat. Well, do you remember nutrition? Do you remember fat is the highest calorie per gram of all the nutritions? So they're not getting proper nutrition. So how are we going to remedy that? Well, they can't have fat. They can have carbohydrates and protein. And you're going to increase those, of course. And you also are going to try to avoid fat so they don't stool it out all the time, right? So how are we going to diagnose cystic fibrosis? Well, no stool at birth, and you're worried, could be, we're going to do something called a sweat test. And all that sweat test does, they put little tabs on the skin and they measure sodium in the skin in the sweat. And it was going to show extremely high levels. How do we treat it? Well, if you're having chest infections, antibiotics, all sorts of medicines to thin, loosen, albuterol, Pulmicort, everything to get all of the secretions up. CPT, those vests that are electronic that and they move the chest around. This is what they need twice, 3, 4 times a day. Now, how do we deal with dietary? Well, there is a pancreatic insufficiency. So we give something, a pancreatic medicine, and it helps a little bit with the fat absorption and the stools. And that's usually called pancreatase. All right. There are capsules that you open, you put on the food. There's also powder that you can use. Now, those little beads in that little capsule, you never crush. You can put it on a little bit of food, and it should be immediately before they eat. So a little bit of something, and then they can eat all of their food. Same thing with the powder. And the one thing with powder, make sure they rinse their mouth afterwards. It's going to hurt their teeth. Just like some of those inhaled medicines, Symbicort, Advair, Brio, those asthma medicine that you need to rinse the mouth afterwards. Same concept here. And the other thing that we forget with any chronic condition is that children need to be watched as they grow. Some kids grow 10 pounds in a year. The dose needs to be adjusted. Actually, I think in all diagnoses, we forget this. Child gained 5 pounds. We need to increase the dose here. So, airway clearance, bronchial dilators, physical exercise. What do you think would be a great physical exercise for cystic fibrosis? You don't want allergens and all that. A swimming pool, right? Get them underneath the water. They're holding their breath. That's PEEP in their lungs, and it will open their lungs. It's actually a great thing for many, many diagnoses. And again, if they get infections in their lung, they do aerosolized gentamicin, tobramycin, and that goes directly, that antibiotic, into the lungs. And of course, they always get PICC lines, IV antibiotics. they are chronically ill with upper respiratory infections. So we're going to give those pancreatic enzymes, high protein, high calorie, as I said, and we got to make sure that those bowels keep moving because one of the thing is constipation, making sure that it keeps going. And then of course, if they're having reflux, some of them do, making sure that we give medicine to they don't have all of that reflux going on. Now, one of the things about cystic fibrosis, women can get pregnant. It is a high risk pregnancy, of course. But men, apparently, there is this mucus in their vas deferens, and the vas deferens is where the sperm lies, and it can't get to the woman. Okay, so they can't, have a baby. So if they do a bilateral lung transplant 1 year after, the possibilities increase and they can have children. So many men decide to do that. Sleep apnea, I think, somebody who snores, children snore too. Remember, if you're not sleeping well at night, you're going to be tired during the day and behavior problems could happen. Doing that sleep study, even in children, does help. Sometimes they do adenoids and tonsils just to open up the airway. Some children do need that CPAP BiPAP. It's just air blowing into them at night to keep them from breathing, from not breathing. Now, acute respiratory distress syndrome. This is when your lungs have been hurt, whether it's from infection, trauma, drugs, or drowning. Probably your most acutely ill child in the PD ICU. So mortality rates are high. Now, you see all of that spaghetti of tubing on the right of that child? That is ECMO. And what it does, it pulls blood off the child into a machine, gives it oxygen, and puts it back in. So it allows the lungs to rest from that acute injury from either infection, drowning, trauma, etc. I actually learned how to use that. And it is quite amazing how it does work. And then as the child gets better, they turn it down and let the lungs breathe more and they can pull it off. And we've saved many a child with using that, all ages. Now, CPR, always remember it. Remember the last exam had a question on it. You're going to see it. But also remember there's parents involved. And remember that the parent is at the bedside when a child is going through CPR to remember to have somebody with them because they're hurting. They don't know what's going on. Okay. Sometimes we need to pull them away. But if we can, today, which is great, not like it was yesteryear, we let the parent stay there, hold that child's hand. At least that parent was there in case something bad happened. Now, asthma. How many of you have asthma? Child has asthma or know somebody with asthma? It is just this bronchial hyperresponsiveness and it spasms and they can't breathe. I mean, usually young children grow out of it, but we do have children that grow up to teens and adults that still have it. My husband has asthma at age 60 something, okay? Now, how do we diagnose? How do we manage it? Well, when a child is feeling well, really good, we'll do pulmonary function tests. We know what's going on with them. And we're going to find out what are they allergic to? What's that allergen that attacks them that make them feel like, oh, my lungs get swollen and I can't breathe, right? The other thing is with children with asthma, make sure they have their little rescue all the time, but try them to be them as normal as possible. I mean, if they're allergic to grass, they can't be playing soccer and baseball, right? But they can do swimming, they can do tennis, they can do other sports. I mean, that's, the trade-off with asthma here. So you try to prevent them from going bad. So how do we treat it? Well, we have those things that we give morning and night to prevent bronchospasms. In children, the med is called Pulmicort. It's an aerosol that we do give to them, right? As they get older, there's other inhaled things we give, Ventolin, etc. but has a little bit of steroid in it. Not a lot, just enough to prevent aerosols. Remember, we have the rescue, always albuterol, right? That's one of the ones that we give. And then in the case of severe asthmatic moment, they're going to give corticosteroids. Now, if you've ever seen staticus asthmaticus, as I call it, it's not, it's, you can see the panic and fear in these people's eyes. Now, the reason why I know, my husband, about 6 years ago, was 12 days in the ICU with status asthmaticus. This man was going in and out of it. He couldn't breathe. I mean, what happens is the air goes down and it gets trapped, and you're coughing and you can't get air out. You can't breathe. You're hypoxic. You're tachycardic. You're anxious. You're just, you don't know what's going on. And it is something that gotta take this child, as I did with my husband, calm him down, talk him out of it, and they can relax and through all the meds, all of the aerosols, the albuterol or the levobuterol or whatever that is, aminophylline, steroids. It can relax the lungs and let them breathe. But status asthmaticus, the goal is to get the lungs open so they can breathe again. It took to the point of magnesium sulfate on my husband 12 days later. COVID is another one of those respiratory treatments. We know there's immunizations out now. I mean, that's very aware and open, today. All right, cardiacs. Now, cardiac dysfunction, probably my favorite of all topics. I worked in our hospital. I opened the cardiac intensive care unit with a physician who came down from Harvard, and it's near and dear to my heart, and I understand it. So just remember, when you're thinking about a heart, think about the blood flow as a hose, and if it gets kinked, where does the blood flow if that hose kinks? And that will help you through this congenital heart defects, okay? So congenital children are born with it. They're born with a multitude of different things. And then sometimes due to infections, and actually use viral is usually the one they get. Autoimmune, think about lupus, right? Environmental, or, the family has those tendencies. Now, if you don't remember the heart and all the structures, I encourage you to go back and look at what the valve names are to know that if the pulmonary or a valve gets a kink in it, where does the blood go? Goes back to the right ventricle, up the tricuspid valve, into the right atrium, and then it goes to the liver, and you'll see swelling in the liver because that's where the blood goes. Conversely, if it happens on the left side, if the aortic valve is kinked, that left ventricle is going to stretch, and it goes through the mitral valve into the left atrium. And where's it go then? Back into the lungs and fills up. So please go back and look at that. Now, I'm going to give you a situation. There's something called coarctation of the aorta. And if you look at the left ventricle and that red tube that goes up and around with the three things that go up, the external carotid, internal carotid, go right up to the head, right? And it goes down and it goes to the body. And it carries all that oxygenated blood to the body. Well, what if there was a kink in it? What's going to happen? So that goes down to the body. There's a kink. That means minimal blood flow is going down. Well, what do you think the pulses on your feet would be? Your dorsalis pedis, your posterior tibial. They're going to be decreased. It's decreased blood flow. Also, the blood pressure is going to be decreased because there's no blood. Now, what's going to happen in the upper extremities? Well, there's extra blood flow going on. It's going to go back. Remember kink. going to go back in the left ventricle, left atrium. It's going to fill up the lungs. So you're going to have all this fluid in the lungs. And with all the extra flow going up, blood pressure in the upper extremities is going to be higher. I've actually diagnosed one coarctation as a nurse. And it's even really before I even understood what a coarctation was. I found an infant, had no pedal pulses, took the blood pressures, and I went, oh, look at this. And then I figured out it's a coarctation. So that's one of the diagnoses you might see. So I had a 3-month-old infant who had coarctation of the aorta. Nobody understood where she lived on the west coast of Florida, what pediatric cardiology was all about. And they kept saying it was upper respiratory. I don't know. And finally, she was in congestive heart failure, and they sent her to us, East Coast. She had a history for feeding. She was tachypnic. She was tachycardic. She was small. She poor weight gain. She had no tolerance. She could barely eat without falling to sleep. And because she wasn't getting nutrition, developmental delays, okay? There was no problem with prenatal history. There was no problem with family history. It was just those symptoms. Now, this is a great diagnosis to remember. Poor weight gain could be caused by inadequate oxygen perfusion, leading to activity intolerance, resulting in diminished energy to breastfeed. Makes sense, doesn't it? You don't have oxygen, you have no sort of tolerance, to do anything, so you're not going to eat. So what happens? All of these children are lower than normal weights. When you look at these children, of course, you're going to look at their nutritional status. What's their color? Looking at their chest. Is there any murmurs? We're also going to be looking at uh, putting on an EKG, looking at their rhythm. Is it regular? Is it fast? Is it slow? What does their heart sound like? Is there a murmur going on? And then if we hear any of these things, have any suspicion, they're going to be doing an echocardiogram. Now, the echo shows flow and stuff that's not right. And then if they figure that out, absolutely prepare. This child's going for cardiac cath, and it's for a diagnostic. They're going to find out this child has this, that, or the other cardiac problem. And then the surgeon has a map of what to do to be able to fix it when they do surgery. Now, sometimes they do interventional. It could be to patch a hole in the upper heart or the lower heart. Actually, where I worked, did the first Helix device on a child and on an adult, actually. And what it is a double plate, and they put it through the ASD. So there's a plate on this side, and it covered it so they didn't have to do any open heart surgery. They did it in a cardiac cath, and it went extremely well. The other interventional might be an electrophysiology study, and that's used when children have, even adults, tachydysrhythmias. And there's some place in that right atrium that doesn't calm down. It should be the SA node that originates a heartbeat. Well, something else says, oh, I'm going to try. And it, delivers a tachycardia. Well, they go and they zap it and say, nope, no more, and let that heart beat at a normal rate. Now, as a nurse, you need to know how to take care of these children. Now, pre-procedure, it's just usually holding their feed, and it's usually infants. So we don't keep them NPO long because their blood glucoses go really low really quick. So up to 2 hours before they go to procedure, we'll feed them. They go to the procedure, they come back. What's the first thing I'm going to look at? Well, I'm going to look at their dressing, where they put in the right femoral artery, the right femoral vein, two catheters to do this cardiac cath. And there's a pressure dressing placed there because the biggest risk is hemorrhage from that catheter site. So making sure that dressing is dry is what we need. Now, what would you do if that area was soaked with blood? Well, it's a big vein. This child is going to desanguinate really quick. You take two fingers above the area of the where the site went in, those two catheters, and you push it down. And then, of course, you call the doctor to come evaluate what went on. Do you need to do something with it? But post cardiac cath, you take vital signs. Of course, check the dressing, do vital signs, check the pulses, document it. Look at fluid. Are they alert? Do they want something to drink, or is there IV fluids? And we're always going to monitor those blood glucoses because, as I said, some of these young infants, they'll go very low very quickly. So we want to make sure they have enough fluid on board. Now, congenital heart disease. One of the biggest thing is that ventricular septal defect. Well, what is that? In between the heart, between the right and left side, the atriums and ventricle, is a thing called a septum. The area between the right upper heart, the right ventricle, the right atrium, and left atrium is a septum. If there's a hole, that's an ASD, an arterial septal defect. If that septum between the lower chambers, the right ventricle and left ventricle, there's a hole, that's a ventricular septal defect. And if there's one of either of them, you're going to hear it. Would be the heart sounds that you would hear, not like you normally hear with a heart, okay? Now, biggest cause is these trisomy children. Down's children are one of the things we look at first is cardiac, making sure there is nothing. VSD is the littlest thing that they can have. Some have it, some don't. Some have even more severe AV canal or other things, which you don't have to know about, but they do have congenital defects. Now, the one thing you need to know about congenital defects is, do they make them with oxygen or without? So acyanotic, they still got oxygen going around. So, all right, we're all right. We got time here. Or, oh, no oxygen's going anywhere. We need to get oxygen to this child. That's your cyanotic, okay? The other thing you need to remember is shunting. So let's look at blood. That left ventricle pumps out really hard flow, and it goes all the way around the body. So left side's got high pressure. And it just gets up to that right atrium and ventricle. So it's very low pressure. So what if there was a hole between the right atrium or right ventricles? It's going to go from the left to the right, and that would be that path of least resistance. So it would mean that if you had an ASD or a VSD, you would have an increased pulmonary blood flow. And that's what this chart out of your book is talking about right here. Now, another thing I need to talk to you about is that patent ductus arteriosus. Now, in maternity, you were taught there's fetal circulation. And that fetal circulation is all about connecting systemic to pulmonic circulation. You want to have the lungs connected to the body so oxygen goes around. And it connects the pulmonary artery to the aorta. So pulmonary artery, that is your oxygen, to your aorta. It's going to go to the body, okay? So that is what a PDA or patent ductus arteriosus is open. Now, usually mommy intrautero secretes a hormone called prostaglandin naturally, and it keeps it open. Once the baby's born, it's gone, it usually closes. Well, sometimes we need to keep it open because we need oxygen. There's no other way that it's happening with this congenital heart defect, okay? We can give synthetic prostaglandins in a slow, continuous infusion, and it will keep oxygen going around. Well, conversely, sometimes it's kept open and we don't need it. Like, why are you still there? It's still pumping stuff around, and we don't need that. We can close it medically with a medicine called indomethacin. I'm going to tell you that again. All right, it's another slide. Obstruction, coarctation of the aorta. Just talked about it, right? And then any valve that's stenosed. Now, stenosis means a narrowing. Doesn't mean that it's closed. That's an atresia. That is the next one over, tricuspid atresia. No blood is going from right atrium to right ventricle. The other one, there's a narrowing. Now, one of the most common of all tested diagnoses you'll ever see, HESEs, exams, NCLEX, is tetralogy of Fallot. Now, tetralogy of Fallot is that pulmonary artery, and it spasms and closes. Now, what happens when the right ventricle can't get blood through that pulmonary valve into the lungs? There's no oxygen going on, is there? So, what would you see? Now, it happened to me one time, called a TET spell, and it happened about 4 or 5 o'clock in the morning on a newborn child, and his name was Nolan. I'll never forget this little boy. And he went from O2 sats of 100, went down to sats of 10 in within a minute or two. And I'm like, and he went from pink to black. It was, oh my goodness. What did I do? Well, there's a position you can do. Take the knees and forcibly, quickly push him to the chest. And it changes the pressure of the abdomen to the chest, pops open that pulmonary valve, and then blood could flow to the lungs. So that's tetralogy. These children, you'll see a lot of questions. They're smaller. They go through these spells. Some are older that aren't repaired yet, and they just sit and squat when they're 2 years old, when they're feeling this coming on. And again, it's that knee to chest thing that they've done. And the other thing that needs prostaglandins open is transposition of great arteries. Now, that's when your pulmonary artery and your aorta are switched. So that means there is pulmonic flow, systemic flow, and there's no oxygen going to the child. So if we keep that duct open from the pulmonary artery to the aorta, we're letting blood flow with oxygen to the baby. And that's transposition of the great arteries. Sometimes it's called an arterial switch when we switch them. And because we've got it open and oxygenated, many of these children, we wait for a week before we would do surgery because they're getting oxygenated. We want them a little bit stronger. And that's very common on these child. So transposition of great arteries, that using that prostaglandin, keeping open that PDA, is a lifeline. So PDA, how do you know it's open? How do you know it's working? How do you know the med's working? Or how do you know it's open that you're not giving meds to? Well, many infants born at birth, that you would look at have an arterial line in, usually an umbilical artery catheter, right? Which is looking at the blood pressure. Well, a normal blood pressure on a neonate, which is a brand new born infant, is 60/40. Well, their blood pressure is 60/18, wide pulse pressure. PDA is open. Now, if you wanted it closed and we're giving medicines, that 18 is going to go back to 40 when it closes. So it's really fun to watch as you're giving this medicine and watching it close. And you're going to hear a washing machine loud murmur if you listen to the chest. So prostaglandins keeps it open because it maintains cardiac output and oxygen saturations. And when you don't want it, you don't need it, you can close it. and it's like being stubborn, like, I'm not giving you anything. Why are you still open? Give them indomethacin. And usually it's IV 3 doses. Okay. And indomethacin is an NSAID. And usually you'll watch that blood pressure go back and you'll stop hearing the murmur if you're listening. So there's a bunch of different pictures here that show you the way things go. I left them there for you to look at. Now, congestive heart failure. Remember that 3-month-old who came in, coarctation, and the blood's going back? It's now into her lungs. She's in congestive heart failure. What happened? Well, of course, it has to do, we got to fix that coarctation. But in the meantime, what can we do? This kid is tachypnic, tachycardic, hypoxic. The lungs are just full of fluid. So let's improve that cardiac function. Digoxin is a great choice on these children. Tetralogy, great choice with those children. And let's get rid of the fluid. Let's give them some Lasix, furosemide. Get rid of the fluid. Put them on digoxin. You're decreasing cardiac mans. You're improving tissue oxygenation. And we're watching their weights because as they start urinating off the fluids, their weight will drop. We'll know they're going into congestive failure if they're gaining weight quick. Like, ooh, let me listen to the lungs. Ooh, where did that fluid go? It's in the lungs. That's why we do daily weights on brand new infants, whether newborn ICU, cardiac ICU, doesn't matter. We're looking at weights. So digoxin, how do we give it? Just like adults. But our heart rate's not going to be less than 60. It's probably less than 100 that we would hold it for. Make sure you check the potassium, check the dig level, do an apical pulse for a minute. And sometimes the only thing that's telling you they're in dig toxicity is they're vomiting, right? Vomiting, nausea, yellow spots are the things you were taught about digoxin toxicity. Well, they can't tell you there's spots in their eyes, but they can vomit or be retching. It's telling you a story. So hold it, call the doctor. Now, hypoxemia with the cyanotic children, what does the body do when the body's hypoxic? It says, let's try to make some more red blood cells because red blood cells do carry oxygen. And more red blood cells doesn't mean there's more oxygen because there's only that amount. So what would you see with these children? Well, these children get, excuse me, what we call polycythemic, which means babies are born hemoglobin hematocrit 1442, normal. When they start trying to make these red blood cells to carry oxygen, it's not available anyway, but they keep making red blood cells. You might be 18 over 54 hemoglobin hematocrit. That's what polycythemia is all about. And we know chronic hypoxemia causes clubbing, and that's a great picture there, that hand. So always with these families, I'm always talking to them. I tell you, cardiac families are usually some of the nicest of all. Teach them, know what's going on, keeping them informed, because they have to go home with that child, take care of it, and be their ears and eyes. Told you about cardiac cath. Bacterial endocarditis, adult children, same thing. If you have it, it's going to be treatment, high dose antibiotics, and lifelong. They're going to be prophylaxis in order before dental, before anything, giving a dose of antibiotics. Now, rheumatic fever is related to the heart because it affects the mitral valve. It is due to a strep infection that wasn't treated or undertreated or not treated, okay? It is where all of a sudden this child is going to have swollen nodules on the joints, going to have rash, going to have this chorea where they can't control their movement, and they're, of course, their throat's going to hurt. So what would be a great question to ask the family when we see these symptoms? Well, has your child been sick lately? And if they've been sick, you would ask if their throats hurt. And what we would do is draw something called an ASO titer, anti-streptolysin titer, strep. And if it's positive, guess what? It's a strep infection. And what would we do to treat this? Well, we're going to give long-term antibiotics. We're going to give, it could be 4 weeks, 2 months, it could be whatever it is to take care of. All the symptoms are going to go away, except if the heart valve, the mitral valve, is damaged, there's nothing we can do. Nothing we can do at all. The damage is there, and they're going to have to treat it medically. They can have high cholesterol. We never thought before. We're looking at that. Children get all sorts of dysrhythmias. One of the youngest children I had with a pacemaker was under 2 years old because she had Brady dysrhythmias. If their lungs have been damaged and hurt, they can go into pulmonary artery hypertension. Like adults, same thing, where their lungs don't work as well and they're tight and they're not exchanging oxygen well. Whatever they do, little movement, they're going to get tired, dyspnea, chest pain, they're going to get dizzy, no oxygen's going to them. And then, as I said in the very beginning, sometimes these heart problems are something that happens due to an infection. Many times, cardiomyopathy or enlargement of the heart, floppy, not working well, is due to a viral infection. There's other things that can happen, deficiencies, metabolic, etc. But many times it's due to a viral infection. Now, we can only fix it, give them tune up so many times, and they end up with a heart transplantation. Know that transplantation, the biggest problem for death is rejection. We try to match them up good, but the biggest problem that we are concerned about is rejection. Now, children do, after surgery for the heart, have chest tubes in. Could be 1, could be 4, could be 5. It all depends what's going on there. Now, remember, especially if the child's old enough to understand, make sure you take the vitals, give them something for pain. I've worked in the adult open heart area on the night shift, and 6 a.m. was the time they pulled out all the chest tubes. So I've pulled out hundreds of adults' chest tubes. And what they all say uniformly, it is intense burning and pain. And then all of a sudden it's gone. So please be honest. Tell the child it's going to hurt a little bit, but it's going to go away pretty quickly. And of course, everything always on their developmental level. And then after it's over, because you've given pain medicine, take their vitals again. When I first started in peds, we didn't do young blood pressures, but we have found out there are young children with hypertension. What does hypertension do to adults? It kills kidneys, right? So same thing here. Kawasaki. Kawasaki is a acute systemic vascularitis. That means the vessels get inflamed. Our biggest concern is the coronary arteries and an aneurysm. These children come, they've had a cold, fever, treated like a virus. They don't know what's going on, but all of a sudden their eyes get almost glow in the dark red. It's very distinguishable. Their tongue is strawberry. They might have swollen glands. The palms of their hands, the soles of their feet will peel or they'll be blistered, and you'll see that. And usually they have to call an infectious disease to come down and look to diagnose it too. But what is the treatment? Well, it's a virus. Or it's not a bacteria. So what they do is they give IVIG, intravenous gamma globins, and they give high dose aspirin. This is the only time we give aspirin. And why aspirin? it prevents clots, it thins the blood. Sometimes some physicians today are putting them on Coumadin instead of aspirin, but usually I've always seen high dose aspirin. We know COVID, we talked about it. Shock, you need to know the signs and symptoms. Know that septic shock infection is the number 1 thing with your young children. Anaphylaxis, kids are getting meds for the first time. We don't know what their responses are going to be. Always be prepared for that and know what the signs and symptoms are. As I said, septic shock is an infection, and one of the ways to prevent it is understanding what those early things that we see. Many times, the ones that are affected the most are those in the newborn ICU, those premature infants. I mean, what would you see with an infection? Well, periods of apnea and bradycardia. Once you see that, let the doctor know. They can, draw all of the labs they need to rule it out and start antibiotics. What about your adolescents, toxic shock syndrome and tampons? Making them aware of it so they know what's going on. And then our last question. Surgical closure of the patent ductus arteriosus would result in one of the following. Well, PDA connects the aorta to the pulmonary artery, and it gives oxygen to the body when no other method is there and available. Remember, the aorta's got a lot of pressure. There could be flow going back into the lungs, right? So it just prevents it from going back. Pretty heavy, huh? A lot of different things, respiratory, cardiac. All right, I got a cahoots for you, and I think it's going to explain a lot of these things for you. Anybody have any questions? So again, I gave you a handout and I gave it to you with the answers. Again, those are the things you need to know. Okay? There's 20 different things. You know that, you are golden. Anybody else coming? Let's just get going. Week 5, respiratory and cardiac. A majority of upper respiratory infections are caused by what? And it's viruses. You take your kid to the doctor, they have this upper respiratory, they have this fever, you think they need antibiotics, they say it's a virus, go home, it's nothing. And you're like, I wanted antibiotics for my kid, but usually it is a virus. Down's children are more susceptible to which medical conditions? This is right off of your discussion question. And this is part of the comments that I wrote there. Hypothyroidism, leukemia. Oops, I forgot to change it. Yes, of course, congenital heart defects. Diabetes, no, but you didn't know about leukemia. I mean, Down's children are clumsy. They could go into an ER full of bruises, and you just think they're just clumsy. Don't forget, they could be leukemia, and leukemia, one of the symptoms is bruising because their platelets are low and they cause bruising, okay? So it is those three, not diabetes. You walk into a 6-year-old's room and you find them not breathing and doesn't wake up. What are you going to do? I threw a CPR in there for you. Remember, there's one-man CPR and there's two-man CPR, right? First thing you do is start chest compressions. And of course, I know me, I'd be yelling for help as I'm doing those compressions, or pushing the button over the head. But yes, you start with chest compressions. And one man, you're going to do the 30 compressions. Two man, two breaths, and 15. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? Kids that are sick, upper respiratories, nose are full of mucus. What are you going to see in them? Remember, they usually have a fever, right? I'm going to give that one to you. But remember, sometimes they just stop eating. Sometimes they'll vomit, abdominal pain, poor appetite if you let it go for a while. But a kid who's not eating, there's a problem, especially if they don't want their favorite foods. Check their temperature. Once you get it down, they'll eat and they'll drink, which is what we want. Multi. What do you do when assessing respiratory function? What do you look for? What's important to look at? We look at everything. How fast? How deep? Are you labored? Is it easy? These are things that we're going to look at. And of course, the rate, right? That's very important. Is it fast? We want to know what's happening here. What would you look for after a child with a tonsillectomy? So remember, they've got those scabs in the back of their throat. They've cauterized them. What would be a concern for you? Now, what if they were swallowing more than usual? What would that mean? What that means is they're probably bleeding. Okay, so swallowing would be a big thing. Now, you're not going to open their mouth and look in it and stick a tongue depressor and look back there. I mean, sometimes just a little open their mouth slightly, they're going to see blood all over their tongue. You know that they're bleeding, okay? Big thing is watching out for bleeding post tonsillectomy. A multi. Nursing care of a child status post tonsillectomy include, how are you going to take care of this child? Back of their throat, we've done this cauterize. I had a tonsillectomy at age 21, and I'll never forget how I felt. Make sure they have something for pain, okay? They used to give some more narcotics, but today they're just giving acetaminophen, and they found out that works just as well. We're not going to give anything spicy that will irritate it. Gum for those older kids, because their ears feel like they're up in an airplane ready to pop. And if they can tolerate it, an ice on their neck. Um, Toddlers usually don't want it. Some preschoolers may, but that ice does help if they'll take it. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? What is that called? Remember, we treat it with cough suppressants, usually. I mean, many physicians order a Z-Pack. I mean, that's usually what they order. But it's called bronchitis. But the other name is the trachea and the bronchitis are inflamed. It's the same thing. Tracheobronchitis, bronchitis are the same thing. Asthma and pneumonia are something completely different. Multi. What signs and symptoms would you see in a child with otitis media? What is otitis media? Middle ear infection, inflammation. The biggest thing, and the one that we need to treat as nurses, is the pain. Because, yes, it is an infection. They're going to go home probably on amoxicillin or Augmentin or one of those. But it's the pain that really hurts. So you want to take that pain away so they do drink. They don't eat. And sometimes they have this ooey pus dripping out of their ear. So that's what you would see. Now, you don't always have a fever with an ear infection. You don't always do. So that's the difference here with ears. The monthly immunization for RSV is it's Synagis. Yes, it is palvizumab. And again, it's only the first year of life. It's from winter to early spring, or about 6 to 8 months here in South Florida, because what's winter, what's early spring for us. And it will help those immunosuppressed children not get that extra mucus and that a little fever that prevents them from eating and they can't breathe. So Synagis, very important thing. A 4-year-old has been taking meds for asthma, but she's still wheezing. What's some information that you need to ask? What's important to understand? The biggest thing is, what was this child taking their medicine? Is it an aerosol? Is she taking it all? Or is it an MDI? Now, there are adults like chewing gum and walking, some can't, right? It's just like squirting it and inhaling at the same time. Some adults can't. So there is this plastic tube that has a mask that goes around from very small size to adult. You put it on, put the MDI on the end, squirt whatever the dose is, once, twice. They inhale a couple times and they got their meds. Now, infants, smaller children will cry, but guess what? They're taking deep breaths, so it's okay. They got their med. An 8-month-old croup exhibits what signs and symptoms of respiratory distress? So, a child with croup, what would you see? So croup, remember, oral pharyngeal upper airway swelling. What would you see? It means air has a hard time getting in there. So substernal retractions and the restless because you're becoming hypoxic. All the other numbers are normal for a 8-month-old child. And that was what this question was about. Yes, they're going into maybe nasal flaring and those retractions and the restlessness, all the signs of respiratory distress. Signs and symptoms of asthma include all except. Now remember asthma, it's not upper airway, it's more lower. They can breathe in, but they can't. It swells up. Air can't come out. So they have a prolonged expiratory phase. My husband would breathe out. And if I was listening to his breath sounds, at the end of that breathing out, I'd hear a squeak. That's the only air that was moving in and out. Shorten. Remember, lower can't get out, upper can't get air in. Inspiratory, expiratory. Okay? Very important concepts there. Signs and symptoms of congenital heart disease include all except. If their hearts weren't done correctly, what wouldn't you see? So these kids are working so hard to suck, swallow, and breathe, that these children, they're not gaining weight at all. So how do you treat heart failure in children and actually those infants? Well, you would give them more frequent feeds, probably less feed with each one. And the other thing is to make sure they're getting their calories because of the weight gain. We're going to increase calories in formula, and we can do that in the breast milk. There's breast milk fortifier, and that will get the calories that they do need to keep their weight gain. Okay. Those are how we look at it. And, we know that children with this congestive heart failure, biggest thing that we do is daily weights, intake, output, monitoring that. It's fluid. We want to see it leave. What should you not do to children diagnosed with croup, epiglottitis? Oh, tonsillectomy too. So you're not going to put anything in their mouth at all, right? A multi-select treatment for infectious mononucleosis. Remember, kissing disease, monospot tests. They come in, their throat hurts, they still feel horrible, aches and pains. And we are going to make sure, remember, it's a virus. Remember, Epstein-Barr virus. It's a virus. So, not antibiotics. It's rest, antipyretics for the aches and pains and fever, and protect that abdomen. Or you could be like that little boy, fall off at the ATV, and he's no longer with us. A multi. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? You're doing your history, you're talking to the mom. What's some information you really need to know? Remember, I was talking about pertussis earlier, right? And pertussis, one of the big things is you want to know immunization status. That's an absolute. Also, their fevers, and of course, any medications, Tylenol, Motrin, when they take it, so I can give it to them. Apgar's, good job. They're really not as important at all. What is the greatest risk for an infant having a cardiac catheterization? So remember, once you have an echo that has some abnormality, that child, and remember, most congenital heart defects are infants. The biggest thing is all about hemorrhages of that right femoral artery and vein. They're huge and they do bleed. How was cystic fibrosis identified? She had that infant who didn't stool. There was no prenatal testing done. And you do a test. What test are you doing? And you're going to do that sweat test for sure. Multi. What is included in the plan of care for a child with cystic fibrosis? So when you think of cystic fibrosis, remember it's a multi-organ disease. Okay, you can't treat one and not the other, right? We got to make sure this mucus is being eliminated. So it's chest physiotherapy, it's pancreatic enzymes, and of course, they're not getting fat. So we need to increase calories, high protein, high carbs. And remember, they're sweating out sodium like crazy. So it's a sodium diet. Give them a salt shaker, never low sodium because they're losing it like crazy. What is the drug of choice for pharmacologic closure of a PDA? What's the medicine I told you that would close that? And you would know when you see that pulse pressure come back to normal. That's 60 over 18. It's back where it should be. And the pharmacological closure is indomethacin. To keep a PDA open, you continue that hormone prostaglandin. That is what mommy has, and you could give a slow, continuous drip of it. Indomethacin or indocin closes it, which is not a feature of tetralogy of Fallot. Tetralogy is all a right-sided defect. So what is not right-sided here? See if you know your anatomy. So the aorta is on the left side, okay? It has a hole in the bottom chambers, VSD. That pulmonary artery is that big problem. And when it closes, it stretches that right ventricle, and that's why right ventricular hypertrophy. What medication would you hold on an infant that is vomiting? And the vital signs are 98, 88, 32. An infant vomiting. Now, all of those meds you can give to an infant, every single one, they're all adult meds too, okay? But we know, I've said it before, vomiting and the heart rate are the two things that would show you this child might be in that digoxin toxicity. So yes, it's digoxin. Good job. Why would a child with tetralogy of Fallot not gain weight at the normal rate? Remember tetralogy of Fallot, they're going to have these tet spells and they're going to have these hypoxic episodes. So it is inadequate oxygenation leads to decreased energy to feed, not eating, nutrition's down. They're not going to be that normal size they should be. A multi. All are examples of a cyanotic heart murmurs, except from what I've told you so far, cyanotic. Cyanotic means lack of oxygen, heart murmurs. So the two here are tetralogy of Fallot and tricuspid atresia are both cyanotic. Atresia without, there's no movement between the right atrium and ventricle. Tetralogy of Fallot, pulmonary artery shuts down and there's no oxygen. But in OSIS, there's still stuff going and a hole between the two sides, just getting more oxygen actually. ASD, VSD, increased pulmonary circulation. Nursing care following a cardiac catheterization. Biggest thing, number one, assess that insertion site for hematoma and bleeding. Absolutely. Good job. A multi. Nursing education for the cardiac catheterization include all except. So remember, cardiac cath, they've taken the right leg, they've inserted catheters in the right femoral artery and femoral vein. We're concerned about the clots. That's why there's a pressure dressing there. So they will not be ambulating for 24 hours and they cannot bend that knee. It might pop the clot off that right femoral artery or vein and cause bleeding, okay? That's the big thing. We're going to watch vital signs. We're going to watch that pressure dressing, but they're in bed. That right leg is going to be straight. Which information is most important when rheumatic fever is suspected? What causes rheumatic fever? Remember, rheumatic fever is that rash. It's that swollen joints. It is that, movements that are chorea, those things, and it's heart valve damage. It's all because a strep infection was not treated or treated completely. It's all about strep, okay? Rheumatic fever is caused by strep. Remember the ASO titer, anti-streptolysin titer? It's all about checking that strep in the body. Signs of shock in children include all of the following except what happens when you get in shock? I could add about three more things onto this. Okay, hypotension, elevated heart rate, slowed capillary refill, decreased urinary output, altered mental status. All of those things you're going to see in shock. And hypertension, we want to get the blood pressure back up. Which of the following best describes the pathophysiology of Kawasaki disease? So Kawasaki is what we call a multi-system vascularitis that may affect coronary arteries. And our biggest concern is an aneurysm on coronary arteries. So what would you imagine one of the tests that we want to run as soon as we can on any child suspected with this? It's an echocardiogram, right? We want to look at those coronary arteries, making sure there are no aneurysms there. Another multi. A clinical manifestation of Kawasaki disease is I used to love watching children come in and diagnosing this. I said, I think this one's a Kawasaki. It's one of the reasons why I worked in the ER. I got to try to figure things out a lot. Now, one of the clinical manifestations is that blistered palms, the strawberry tongue, the reddened eyes, and yeah, it is that movement also. The one thing that we cannot turn around with with all of the chorea, that is it's not with that. That is with the strep infection, okay? But it is with the reddened tongue, the strawberry tongue, the eyes, the cracked hands and feet, and the fever. And those are sometimes so subtle and hard to figure out, but we can treat them. It usually takes about a month to get rid of it. But what's the treatment? Kawasaki disease. Remember, chorea is rheumatic fever. It's not Kawasaki. And many students get that mixed up. So, Kawasaki, we're going to give aspirin high dose, and that's to prevent clots, the itis, that vascular itis, and IVIG. It helps boost the immune system. Very good. Which of the following is the most common cause of shock in infants and children? It's infection, sepsis. Very good. What are the defects associated with tetralogy of Fallot? So remember, right-sided again. There's only one here that has all right-sided stuff. And that is the pulmonary artery gets small, stenosed. There's that hole between the ventricles. Somehow that aorta gets pushed over. I mean, I know that's the confusing one. And remember, when it closes, that right ventricle stretches are called hypertrophy. A young child with tetralogy of Fallot may assume which position naturally when having a tet spell. I mean, not all children are fixed when they're infants. Some of them go on and they're 2 years old before we fix them. And it's pretty neat that these children all of a sudden will just squat to the floor. And it's like putting a knee to chest, isn't it? Think about it. Transposition of the great arteries is what? This is one of those things where there's no oxygen going anywhere. And you've got to keep that patent ductus arterius open because there's no connection of oxygen anywhere. And sometimes you've got to punch a hole between the atriums to make more mixture going on. This is a very serious thing. Once we open it, that PDA, give them oxygen, and make sure that the exchange is going on. These children can wait a little bit before surgery, and they actually do pretty good. So, which is not an intervention indicated for transposition of great arteries? Remember, this is extremely serious. So we know they have to be on IV prostaglandins. There's no oral anything here that will work. That atrial septostomy is they open up that patent foraminal valley in the atrium. Remember, it's there at birth. They make it bigger to exchange oxygen. They can move it oxygen from the right to the left side. And the name of the surgery they do is called a switch, arterial switch. A multi. Why is prostaglandins given to a child with transposition of the great arteries? What is prostaglandins all about? Connects the pulmonary artery oxygen to the aorta, the body. So it helps with oxygenation and it maintains cardiac output. It is not an antibiotic. It's not used for infections. All it does, it keeps that tube open and it gives oxygen and it lets the heart beat effective. What is the purpose of giving indomethacin to a neonate with a PDA, patent ductus arteriosus? What is indomethacin all about? Again, what the indomethacin does is we know prostaglandins from mommy, or we deliver it, keeps that PDA open. Once that's cut off and it's still open, we give indomethacin. And wherever that prostaglandin is coming from, it says, yeah, no more. And then the PDA does close. You see this a lot with premature infants, where all of it's open, open, open. Whatever we do, it doesn't close. And then we start the indomethacin and we can close it. And then, of course, sometimes we have to do surgical repair. Where is the patent ductus arteriosus? I've said it about 5 or 6 times already. What does it connect? Oxygen to the body. What is that? It connects the aorta to the pulmonary artery. Pulmonary artery has oxygen. It can get oxygen into the aorta and it can go to the body. Oxygenation, cardiac output. This heart defects allows blood to pass from the left ventricle to the right ventricle. How can blood go from the left to the right ventricle? And because the septum between the right and left ventricle has a hole, ventricular septal defect. And then what happens if it's between the atriums, the right and left atrium? It's an atrial septal defect. A multi. What is a sign of digitoxicity in infants? Nausea, vomiting, or retching type thing, and a heart rate that is low. Who's saying seeing yellow spots in an infant? They can't tell you they're seeing yellow spots. It's usually in the adults. Left-sided congestive heart failure causes what? The left side of your heart's not working right. That means blood backs up. Where does it go? And it's short of breath, fluid in the lungs, coughing, filling up the lungs. Very good. After a heart transplant, what's the leading reason children die? And it is rejection. Rejection is number one. A multi. Signs and symptoms of rheumatic fever include, so remember, that's the strep infection. And we treat it by giving antibiotics, right? To treat the strep. And it's everything. You're going to have that sore throat, respiratory distress, the fingers, the joints going to hurt, that weird movement, etc. Everything will be turned around and normal after treatment, except if there's heart valve damage. That is damage. There's nothing that's going to turn that around. You're going to have medical treatment for that. A multi. A child's about to have a chest tube removed. What should you do? Tell them it's going to hurt. Please tell them it because it does burn. Always tell them on their level of understanding and medicate. And you would put spine, actually, you're going to put them a little bit of Fowler's. Elevate the head of the bed a little bit. It helps with the pulling out of it. A child just had a surgery, cannot cough well enough to expectorate their secretions. What is the nurse's priority? How are you going to make them expectorate their secretions? They just had surgery. Abdominal, chest, don't matter. They're not coughing. Number one, medicate them for pain. And then you can reposition, get them out of bed, use incentive spirometry. Can you imagine you just had abdominal surgery, you don't get medicated for pain? Would you do any of that? So again, remember that. Medicate for pain. After that, a child will do whatever you want. An infant has a 3 months has a fever of 103.6. What would you medicate an infant with? 3 month infant, what do you give them for a fever? Only acetaminophen. You can't give anything else till about 6 months, and then you could start ibuprofen. There's something to do with blood coagulopathies, and the infant, they can't tolerate it till 6 months old. A newborn infant's assessed and finds a weak lower extremity pulses. What should she assess next? You have very weak lower extremity pulses. What should you assess next? What do you think is going on here? Probably coarctation of the aorta, right? Blood's not getting down there. So how do you determine? Well, if blood's not going down, you're going to have lower blood pressures on the bottom, higher blood pressures above, so 4 extremity blood pressures. Multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? I think a lot of this is even adults, children, it doesn't matter. You have anybody who's sick, you got to keep their lungs moving, you got to keep them dry and help them turn in position. With children, I've used pillows, blankets, toys, beanie babies, all sorts of things to keep them over, and all of them work. Now, elevating the head of the bed depends on the condition of the child. Some children can't have that bed elevated, and that's why that's not checked. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? Always bring back some questions. And it's an oxy hood. Everything else is either sticking to them and they're annoyed by oxy hood. They can suck a pacifier or fingers and look around and be very happy. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, their lungs are full of mucus. You're doing aggressive respiratory care, right? So what procedure? Most important of all. And that's chest physical therapy number one, deep breathing, coughing, and exercising. And I'm telling you, swimming is probably one of the best things for any kids because they hold their breath, and that holding their breath causes beep, keeps lungs open. A multi. Children with cystic fibrosis require pancreatic enzymes with meals, but teaching should be done. How are they going to take those things? Right before meals, you can open the capsule and put it on a little bit of food if they can't take it all. Again, anything with powder, you're going to rinse the mouth. And the one thing we always forget, make sure we increase the dose as they grow. Very good. What is the cardiac defect where there's no valve between the right atrium and right ventricle? So, what's the valve between the right atrium and the right ventricle? That's your answer. And it is a tricuspid valve. Remember, nothing is atresia. Osis is there's an opening, okay? Remember those words and you'll be okay. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? What do you think is going on here? Probably going into congestive heart failure. So you are going to be looking for breath sounds. So let's see how we did today. 3. Good good job, Gabs. Number 2, Dee Dee. Good job, Dee Dee. Number 1, Chania. Good job, Chania. And Abby and Array. All right, that is the end of tonight. I know it's a lot of information here. If anybody doesn't get it and wants to meet with me, I'm more than welcome to do that with you. Again, remember, send me your diagnoses for your week 8 thing. Some of the diagnoses are closed, so please confirm that with me before you start. Remember to do your CJ Sims and your discussion question, and anything you need, let me know. Thanks, guys. Have a good night.
Thank you.
My pleasure.